Monitor level of consciousness. Monitor vital signs for increased pulse or decreased blood pressure. Monitor intake and output. Assess color, temperature, turgor, and moisture of the skin and mucous membrane. Administer IV fluids, blood, and colloid solutions as prescribed. If the client has spinal anesthesia, remember, if the client has spinal anesthesia, do not elevate the leg any higher than placing them on the pillow. Otherwise, the diaphragm muscles needed for effective breathing could be impaired. The diaphragm muscles needed for effective breathing could be impaired. Thrombophlebitis. Thrombophlebitis is an inflammation of a vein, often accompanied by clot formation. Veins in the legs are affected most commonly. Assessment for thrombophlebitis: vein inflammation, aching or cramping pain, vein feels hard and cord-like and is tender to touch, elevated temperature. Interventions for thrombophlebitis: monitor legs for swelling, inflammation, pain, tenderness, venous distension, and cyanosis. Notify the doctor if any of these signs are present. Elevate the extremity 30 degrees without allowing any pressure of the popliteal area. Without any pressure on the popliteal area. Encourage the use of anti-embolism stockings as prescribed. Remove stockings twice a day to wash and inspect the legs. Remember, remove stockings twice a day to wash and inspect the legs. Use an intermittent pulsating compression device. Perform passive range of motion exercises every 2 hours if the client is confined to bed rest. Encourage early ambulation if prescribed. Do not allow the client to dangle the legs. Instruct the client not to sit in one position for an extended period of time. Administer anticoagulants such as heparin, sodium, or warfarin, Coumadin if prescribed only. Urinary retention is an involuntary accumulation of urine in the bladder as a result of loss of muscle tone. It is caused by the effects of anesthetic or opioid analgesic and appears 6 to 8 hours after surgery. Assessment for urinary retention: inability to void, restlessness and diaphoresis, lower abdomen pain, distended bladder, hypertension. On percussion, bladder sounds like a drum. Intervention for urinary retention: monitor for voiding, assessed for a distended bladder, encourage ambulation when prescribed, encourage fluid intakes unless contraindicated, assess the client to void by helping to stand, provide privacy, pour water over the perineum, or allow the client to hear running water to promote voiding. Contact the doctor and catheterize the client as prescribed after all non-invasive techniques have been attempted. Constipation is an abnormal, infrequent passage of stool. When the client resumes a solid diet post-operatively, failure to pass stool within 48 hours may indicate constipation. Remember, failure to pass stool within 48 hours after surgery may indicate constipation. Assessment for constipation: absence of bowel movements, abdominal distension, anorexia, headache, and nausea. Interventions for constipation: assess bowel sound, encourage fluid intake up to 3,000 ml per day unless contraindicated, encourage early ambulation, Encourage consumption of fiber food unless contraindicated. Remember, encourage consumption of fiber food unless contraindicated. Provide privacy and adequate room for bowel elimination. Administer stool softener and laxative if prescribed only. Paralytic ileus. Paralytic ileus is failure of appropriate forward movement of bowel contents. The condition may occur as a result of anesthetic medication or of manipulation of the bowel during the surgical procedure. Assessment for paralytic ileus: vomiting post-operatively, abdominal distension, absence of bowel sounds, bowel movement, or flatus. Interventions for paralytic ileus: monitor intake and output. Maintain NPO, nothing by mouth status, until bowel sounds return. Maintain NPA status until bowel sounds return. Maintain patency of a nasogastric tube if in place. Encourage ambulation. Administer IV fluids or PN if prescribed. Administer medication if prescribed to increase gastrointestinal motility and secretions. If ileus occurs, it is treated first non-surgically with bowel decompression by insertion of a nasogastric tube attached to intermittent or constant suction. Vomiting post-operatively, abdominal distension, and absence of bowel sounds may be sign of paralytic ileus. Vomiting post-operatively, abdominal distension, and absence of bowel sound may be signs of paralytic ileus. Wound infection. Wound infection may be caused by poor aseptic technique or a contaminated wound before surgical exploration. Existing client conditions such as diabetes mellitus or immunocompromised may place the client at risk. Infection usually occurs 3 to 6 days after surgery. Purulent material or pus material may exist from the drains or separated wound edges. Wound infection assessment: fever and chills, warm, tender, painful, inflamed incision site, edematous skin at the incision and tight skin sutures, elevated white blood cell count. Interventions for wound infection: monitor temperature, monitor incision site for approximation of suture, line, edema, or bleeding or signs of infection. REEDA. REEDA stands for redness. E. Erythema. Erythema. Erythema means redness or rash. Erythema means redness or rash. Ecchymosis. Ecchymosis, it means 1 centimeter of bruise. Ecchymosis is 1 centimeter of bruise. Drainage, approximation of the wound edges. Notify the doctor if signs of wound infection are present. Maintain patency of drains and assess drainage amount, color, and consistency. Maintain asepsis and change the dressing as prescribed. Administer antibiotics as prescribed. Wound dehiscence and evisceration. Wound dehiscence is separation of the wound edges at the suture line. It usually occurs 6 to 8 days after surgery. Wound dehiscence is separation of the wound edges at the suture line. It usually occurs 6 to 8 days after surgery. Wound evisceration. Wound evisceration is protrusion of the internal organs through an incision. Wound evisceration is protrusion of the internal organ through an incision. It usually occurs 6 to 8 days after surgery. Remember, both Wound dehiscence and wound evisceration usually occurs 6 to 8 days after surgery. Evisceration is most common among obese clients, clients who have had abdominal surgery, or those who have poor wound healing ability. Wound evisceration is an emergency. Assessment for dehiscence: increased drainage, opened wound and edges, appearance of underlying tissues through the wound. Assessment for evisceration: assessment for evisceration: discharge of serosanguinous fluid from a previously dry wound, the appearance of loop of bowel or other abdominal contents through the wound. Client reports feeling a popping sensation after coughing or turning. Interventions for evisceration: place the client in a low Fowler's position with the knees bent. Remember, place the client in a low Fowler's position with the knees bent to prevent abdominal tension and on an abdominal suture line. For wound intervention, for wound evisceration, place the client in a low Fowler's position with the knees bent to prevent abdominal tension on an abdominal suture. Cover the wound with a sterile normal saline dressing. Notify the doctor. Prevent wound infection through strict asepsis. Administer antiemetics as prescribed to prevent vomiting and further strain on the abdominal incision. You have to administer antiemetics, which is anti-vomiting, if prescribed. This is to prevent vomiting and to further strain on the abdominal incision, because when you vomit, you tend to strain your abdominal incision. Instruct the client to splint the abdominal incision when coughing. This action assists in preventing or worsening these complications. Prepare the client for surgery as necessary. Client is ambulatory surgery. General criteria for client discharge: you can discharge the client if client is alert or oriented, client has voided, client has no respiratory distress, client is able to ambulate, swallow, and cough, client has minimal pain, client is not vomiting, client has minimal, if any, bleeding from the incision site, client has minimal bleeding from the incision site, serious draining. Client has a responsible adult available to drive the client home. The surgeon has signed a release form. Discharge teaching. Discharge teaching should be performed before the date of the scheduled procedure. Provide written instructions to the client and family regarding the specifics of care. Instruct the client and family about post-operative complications that can occur. Provide appropriate resources for home care support. Instruct the client not to drive, make important decisions, or sign any legal documents for 24 hours after receiving general anesthesia. 24 hours after receiving general anesthesia. Instruct the client to call the surgeon, ambulatory center, or emergency department if post-operative problem occurs. Instruct the client to keep follow-up appointments with the surgeon. Actions to take if evisceration occurs: call for help, ask the surgeon be notified, and that needed supplies be brought to the client's room. Stay with the client. While waiting for supplies to arrive, place the client in a low Fowler's position with the knees bent. Cover the wound with a sterile normal saline dressing and keep the dressing moist. take vital signs and monitor the client closely for signs